Good morning, everybody. My name is Professor Paul Tipton. I am Director of Tipton Training Limited and President of the British Academy of Restorative Dentistry. The webinar today is going to focus on margin design for restorations. And in particular, we're talking about indirect restorations. So we're talking about crowns, different type PFMs, ceramic, etc. So first of all, we need to talk generally about tooth preparation. And there's two books here which I would suggest that you, if you want to improve your tooth preparation, you go out and borrow, beg, steal, buy. And those are both by Schillingberg, the guru, the master of tooth preparation. He's written the definitive book and the definitive texts, scientific papers on tooth preparation. And the two books are Fundamentals of Tooth Preparation and also Fundamentals of Fixed Prosthodontics. The Fundamentals of Tooth Preparation literally gives you a step-by-step guide as to how each tooth preparation should go. Everything from veneers to bridges to PFM crowns to ceramic crowns to gold three-quarter crowns, etc. Everything's covered. And in the Fundamentals of Fixed Prosthodontics, he covers that in not quite as much detail, but also then goes into the impression technique, cementation, occlusion, etc., etc. So, reviewing the tooth preparation techniques, I want to just go through very rapidly some of the aspects that you have to be aware of before you even pick up a burr and start to prepare. The first thing you need to understand is tooth anatomy and how much preparation that you can do dependent upon the amount of enamel that's there. So just to review, if I was going to be doing a veneer preparation for a central incisor, that's why we're looking at margins today, and what type of preparation will I do? I need to make sure that I stay in enamel. And if I stay in enamel, then I'm going to get better bonding. And therefore, I need to know the anatomy. So it's really important for you that you understand tooth anatomy and exactly how much enamel is there at the gingival margin of a central incisor. And you see that there's 0.36 of a millimeter. Now, if I'm going to put a veneer in place, I need to make sure I stay in enamel. And therefore, the maximum preparation that I'm going to be using is going to be 0.3. In some instances, if I see there's erosion going on in the mouth, then I'll bring that down to an even thinner, smaller margin, maybe 0.1 or 0.2. So remember, these are averages. If we now look at a lateral incisor, and it may surprise some people to find out that on average, there's a greater amount of enamel present on a lateral incisor than there is on a central incisor. And there's in fact 0.39 on average. So coming back a little bit, the maximum preparation I'll ever do is 0.35. And again, if I see a smaller tooth, if I see somebody who's an older patient obviously has brushed their enamel away a little bit more. Somebody's got erosion somewhere in the mouth, then that's affecting the amount of enamel that's there. And therefore I will come back a little bit more. We move on to the canine. I'm not going to go through every single tooth in the mouth, but we'll end up on the canine. And again, canine, bigger, bulkier tooth. And you would naturally assume there'll be more enamel there. But if we look, there's less, on average 0.29. So what's happening here? Well, if you can imagine, the canine is a much darker tooth. Why is it darker? It's darker because there's more dentine, there's less enamel. So again, everything goes to say that my maximum preparation now, 0.25. And it will come down dependent on, as I mentioned, smaller teeth, older patient, erosion somewhere. When we're doing crown preparations, generally, we must also remember how much tooth tissue there is in terms of enamel and dentine before we go into the pulp. So again, we have to understand that in the mid-labial position, okay, on average for a central incisor, you've got about 2.5 millimeters of tooth tissue before you get into the pulp. Less on a lateral incisor, about 2.3, more on a canine, about 2.8, 2.9 millimeters. So we have to understand anatomy generally. The next thing we need to understand if we're going to prepare properly is using the correct burrs. And it's really important that if we're talking today about good tooth preparation, we need to be precise. Everything comes down to precision. And the only way that we can be precise is by understanding the shapes, the inclinations of the burrs that we're going to be using. And therefore it's important that you get yourself a set of digital calipers, that you start to measure the inclination of your burrs. So if you're using a tapered burr, then you have to understand the inclination of that tapered burr. Because ideally, the inclination of the tapered burr, if we hold it so that the burr is completely vertical to the long axis of the tooth, then we will cut with a certain amount of angle. And what we're wanting for PFMs is around about a 12-degree convergence angle. So we need to pick the right burrs. We need to pick the right burr at the cutting tip. Again, the cases that we showed you just before with the tooth anatomy, if we're doing veneers for those patients, we'd be cutting and using a chamfer. And with a chamfer, we use, if you remember, half the thickness of the burr to cut a chamfer. If we use the whole thickness of the burr to cut a chamfer, then unfortunately we get that little lip there, which can interfere with our impression taking. It can also interfere with our seating bar restoration. So it's really important that we understand that we use half the thickness of the burr. Therefore, if I'm going to do a 0.3 millimeter chamfer, I need to pick a burr which is 0.6 of a millimeter at the cutting tip. So really important that you understand burr sizes. Next part is two-handed tooth preparation. We need to understand that we do two-handed tooth preparation wherever possible. If we do two-handed, we have more control, much more control than one-handed. So wherever possible, we'll try and do precision prepping with two hands and direct vision. Direct vision means that we can see an awful lot more. So if I'm doing the mid-labial aspect, you can see I've got two hands on my turbine and I'm preparing on the mid-labial. Now, if I'm going to do the mesial aspect, I ask my patient to turn their head to one side so I can cut through mesially, again with direct vision. I'm going to be doing the distal side. I'll turn the patient's head to the other side and cut through. So I've done 3/4 of the preparation with direct vision and two hands. Much more control. The only area which I've not cut is the palatal. And for the palatal aspect, I'm going to have to work in a mirror. That's really important when you're working in a mirror, that you use a different handpiece. You use a speed increasing handpiece. This is the NSK red stripe speed increasing handpiece. Particularly important these days, I think, because it appears, no scientific studies, but it appears that it may generate less aerosol than with a turbine. And there's a lot of dentists out there that do the whole preparation with the speed increasing. Now, what does the speed increasing give you? It gives you more tactile feel. We live our lives with senses, okay? And you know yourself, if you cut with a turbine, then it's very easy to cut through the tooth and you don't really get that feedback. The reason is that when you cut with a turbine, you use a constant pressure. You use a light constant pressure, like a knife through butter. What happens now, question, is what happens if you push harder when you're using your turbine? Usually it stalls. What happens if you use gentler force? Usually not an awful lot. It doesn't cut too much. So we're using constant force. And the problem with that is that we're not having the tactile feel that we could be having. Let's give you, for instance, how many senses do we use when we prepare teeth? Okay, we obviously use our eyes, vision. We might use our smell, sense of smell, if we feel that the dentine's burning, okay? But the other major one, apart from eyes, is touch and feel. And of course, as I mentioned, with a turbine, you've got very little tactile feedback. The turbine cuts very, very rapidly. Now, what does the speed increasing do? It cuts at 5 times less RPM, but 5 times greater the torque. Now, what does that mean? That means that if I push on harder, it will cut more. That means if I don't push on as hard, it will cut lighter, it will polish. And so suddenly I'm starting to get more feel through my fingertips. Remember, our senses are all about changes. Okay, we walk into a room, and maybe a hotel room, somebody's been smoking. Okay, we can smell. After 5-10 minutes, maybe we can't smell. Why? Because that's a constant smell. Same with pressure. If I put pressure on my arm here, okay, imagine it's somebody else, me putting pressure on your arm. You can feel that. What happens in about 2 or 3 minutes time? Can you actually feel it? Can I feel that I'm putting pressure on? No, because there's no change in pressure. Therefore, the speed increasing gives you that change. And in certain areas, I can now cut blind. So it's an absolute essential piece of kit. If you want to go and be a good prepper, we can talk about why that's important in a few minutes time. But if you want to be a good prepper, use the speed increasing. It's wonderful at finessing preps. It's great at creating margins. And also, very importantly, when you don't have the two hands because you're having to work in a mirror, then use something that also gives you better tactile feel. Magnification, obviously important. We need to make sure that we have good loops for posture. And you're talking to somebody who's had one back operation, 2 discs removed, and a neck operation and 2 discs removed. So I know about having a bad back, and that's come from being in dentistry a long time and also during my professional cricket career. But use loops. Okay, I use the loops with a light on. They're 5.5 magnification, and for me it gives me good posture and I can see. Final thing is make sure you're sitting directly behind the patient. And the reason for this is that most of the work we're going to be doing these days is aesthetic work. And if we're doing aesthetic anterior work especially, we need to understand the various horizontal and vertical lines that we're working to. We're working to the vertical line center of the face. We're working to horizontal lines, either interpupillary line or intercommissure line. The center line of our preparations needs to be at 90 degrees to either the interpupillary line or the intercommissure line. We have to give that information to our technician. So how do we do that? We usually give our technician a FACEBO registration, which sometimes we have to make sure that the top of the framework of the FACEBO is parallel to the eyes. If we do that, then the top part of the articulator will be parallel to the eyes, and therefore our technician now makes the incisal edges parallel to the top part of the articulator. The incisal edges of our crowns come back parallel to the eyes. So it's important that we use a FACEBO. If we're using intercommissure line, then the FACEBO very often obliterates or it makes it difficult to get the true intercommissure line. And for those instances, then we use a stick butt. If you're sitting directly behind the patient, okay, at 12 o'clock, and I'm not saying you have to do everything from there. I'm saying that's where you start and you to the other side and do something, but you reflect and look at it again at 12 o'clock. So your basic position is 12 o'clock. And at that position, you can then start to understand the vertical and the horizontal lines. There's nothing worse for a technician than getting maybe a FACEBO and even a stick bite. But the incisal edges of his preparations are all running up at an angle because the dentist has prepared. He now has different questions he needs to ask himself. Do I make the incisal edges parallel to the eyes, parallel to the lips? Do I make them parallel to the incisal edge of my preparation? What you want is all of that information saying exactly the same thing to the particular technician you're using. So let us talk about general preparation techniques. And we know from our work done in the past, Schillingberg, various other, Samuel Geyer going back many, many years ago, that we have 4 elements to tooth preparation, 4 stages, if you like. And those 4 stages are occlusal stroke incisal reduction, axial preparation, margins, and resistance retention form. And we do them in that order. Now, from time to time, I may go and do the mesial and distal axial preparation first. And the reason for that is I want to cut through the contact area between the tooth I'm prepping and the adjacent teeth. That then means I can put a burr onto the incisal edge or a burr onto the occlusal surface and not damage the adjacent tooth as I'm moving the burr from side to side. But generally, I will prepare and get the occlusal surface correct first of all. And we do that various ways. We have tooth preparation guides. Those can be a putty matrix, and it's a putty matrix of the tooth in the mouth if it's the correct shape. If the tooth in the mouth that you're prepping is not the correct shape, then you need to take an impression, get a model cast. Technician then does a diagnostic wax up, and you take a putty matrix or a suck down, a clear suck down of the actual diagnostic wax up. So that then tells you the end result. Okay, very important in dentistry, as you're all aware. In restorative dentistry, you have to understand the end result. If you don't know the end result, then that's called litigation, because you've not gained consent. If you don't know what the end result is, the patient doesn't know what the end result is, then that ends up in a lawsuit. So it's really, really important whenever you're doing anything that you get a diagnostic wax up done so you can see the end result. We then move on to our axial preparations. And as we mentioned before, axial preparations are going to be different in terms of convergence angle, depending on the type of restoration. So for a PFM crown, a bridge, then we're looking at 12 degrees convergence angle. And that's been shown by Schillingberg to be a nice compromise between easy seating of the restoration when we come to cemented in place, but also good resistance retention form. And we need that compromise. If we move now to ceramic, two things we need to think about is with ceramic. Number one, it's not as strong. Therefore, we can't put as much force on it as we're seating it down. So it needs to seat easier. The other thing we know with ceramic is that we usually use an adhesive cement, and that adhesive cement is usually some form of flowable composite, and that's got a thicker film thickness than the zinc phosphate cement that we should be using for PFMs. Yes, I said zinc phosphate cement. That's my ideal cement for PFMs. And we can have a whole new webinar, different webinar on cementation techniques. So because of those two things, we've got a more fragile restoration and a thicker film thickness. We have to make sure that our convergence angle is now a bit greater. So we're looking, instead of 12 degrees, we're looking at 15 degrees, maybe 15 to 20 for zirconia, 20 degrees for Emax, maybe even up to 25 degrees for feldspatic porcelain. So when you're looking at axial inclinations and convergence, guys, you've got to look at the type of preparation for what restoration you're doing and also the cementation technique. Then we come on to margins, which I'm going to spend the rest of the presentation, and finally resistance retention form. And the resistance retention form can be in the shape of adding extra grooves, boxes, etc. So let's start off our proper presentation and talk about margins. So what sort of margin are you going to put into your restoration? So what influences margin choice? Okay, so we've got three factors here, and I want to concentrate on the final one. So the first one is space. The technician needs space. You know that. The technician needs space in which to create whatever it is you're wanting to create. So if it's a porcelain fused to metal restoration, at the margin, he needs a certain amount of space, usually between about 1 to 1.5 millimeters, depending on whether he's going to do a vertical cutback of the metal framework and have pure ceramic at the margin, or if he's going to have metal underneath the margin. Okay, so he needs that 1 to 1.5 millimeters. For zirconia, then anything from possibly 0.1 up to about 0.7, 0.8 of a millimeter. A lot of this depends on the amount of tooth preparation you want to do, as in being conservative. It may also depend on the color of the substrate underneath. So we need space to give our technician the correct amount of space for color. The next thing we need is we need to think about materials. Certain materials do not lend themselves to certain margins. Let's look at a shoulder, for instance. Okay, ceramic does not go into 90-degree angles. Ceramic rounds. Therefore, it's no use putting a shoulder when you're doing ceramic because it will not fit as well. Likewise, ceramic doesn't do bevels. So certain materials lend themselves to different margins. So ceramic lends itself to a rounded margin. And we're now talking about chamfers. PFMs, metal, lends itself well to either chamfers, but also well to shoulders and shoulder bevels. So you have to take that into consideration. The third one, and the one I want to again concentrate for the rest of this presentation, is about seating and sealing. So Gavalis wrote a very, very good paper many years ago, which not a lot of people ever really picked up upon. And it was the influence of various crown margins on seat and seal. And what that influence, or what that paper shows us, is that it's an inverse relationship. So what do we mean, first of all, by sealing? We mean a margin that seals beautifully at the edges, so you're not liable to get leakage. What do we mean about seating? Seating now is a margin that allows the restoration, when we come to cement it in place, to seat it down properly. And you know what can go wrong if either of those fail. So if we don't have a good seal, we can get leakage, and therefore that leakage can lead to caries, for instance. If we don't have a good seat, it means that we'll have an open margin with a thick cement lute, but also the restoration, once we've cemented it, will be high. There's one of the worst things you can do in dentistry, and I know it bugs me, is if I've done, put my crown in place, done my occlusal adjustments, polished the crown, the occlusal surface, and I'm ready to cement, and I'm trying it in, the patient says, yes, that feels good. And then once I've cemented in place and I take my gloves off, my patient says, hold on, I think it's a bit high now. And you know what's happened, it's not seated properly. Now that doesn't mean to say that the restoration's failed, no. There's always a degree of seating, but what it does mean is it's not seated fully. And that means now I have to put my gloves back on, go back to the articulating paper, adjust it again in the mouth, and repolish it in the mouth. And you know yourself, to go and repolish something in the mouth never gives you the same result as polishing it outside the mouth and cementing it in place. So we have seat and seal, which we need to understand. Now, what we should understand is that there is an inverse relationship between seat and seal. So that the best seat gives you the worst seal. The best seal gives you the worst seat. So we have to understand, when do we need to choose the best seat? When do we need to choose the best seal? So that's also our third reason for choosing a margin. We have to make a decision. We have the best seat, worst seal, best seal, worst seat, or we go for an average seat and average seal, which is probably what we do most of the time. So let's look at those margins. What do we know? We know that horizontal margins, okay, and what are horizontal margins? Horizontal margins are shoulders, heavy chamfers, shoulders or chamfers with a 30-degree bevel. They're all classed as horizontal margins. Horizontal margins seat down very well. Why? Because there's always a big space as the restoration is being seated. There's always a big space for the cement to come out. Vertical margins, they seal. And this is all due to the geometry of the margin. So when we talk about vertical margins, what margins are we talking about? We're talking about light chamfers, 0.1, 0.2, 0.3 millimeter light chamfers. We're talking about vertical preparations. You've heard a lot about vertical preparations. We're going to mention them here. The VertiPrep, the new VertiPrep. That used to be the marginless, prepless finish line, if you like. Okay, so those are vertical margins. Light chamfers, the VertiPrep. The other one is a chamfer with a long bevel or a shoulder with a long bevel. So if our finish line goes towards the long axis of the tooth, remember if our finish line is a shoulder, that's 90 degrees to the long axis of the tooth, that's a horizontal margin. The more then the finish line starts to go, so it becomes in the general longevity of the tooth, the length of the tooth, the angulation that's similar to the axial wall, then it comes to be more of a vertical margin, which is a good margin for sealing. So Gavalis looked at all of these different restorations and these preparation designs, these finish lines, and the effect that they had on seat and seal. And as we mentioned, shoulders, they're good horizontals, so they seat very, very well. They don't seal. Chamfers, okay, two sorts of chamfer. Heavy chamfer seats well, doesn't seal. Light chamfer seals well, doesn't seat well. Bevels, so we have a chamfer or a shoulder with a bevel. That bevel can be at different angles, could be 30, 45, 60 degrees. The 30-degree ones are closer to the horizontal, therefore they seat well, they don't seal. The 45-degree is the average, so that gives you an average seat and seal. The traditional chamfer, the 0.5 to 1 millimeter chamfer, gives you an average seat and seal. And then, of course, we've got the knife's edge, where the angle is similar to the long axis of the tooth, the axial wall, vertiprep, and that gives you, again, good sealing, but poor seating. So when we choose a margin, we have to choose it based on these three things. Now, most of the time, we're going to choose an average seat and seal. Okay, but there's from time to time when we might want to choose something that seals better or something that seats better. Okay, let's just have a thought process on that. So when is it important to have a good seat? Okay, seal will be poor, but we have a good seat. When is that most important? Okay, let's ask another question. When is it difficult to seat a restoration? You're going to cement a restoration down. When is it difficult to seat that restoration? Let's look at some examples. Number one, it may be a fixed bridge. Not fixed movable, but a fixed bridge, where you're pushing down one end, you're pushing down the other, you're trying to seat it. It's not easy. So in those situations, you may decide to go for something that is a better seat, especially for somebody who maybe does not have a history of caries, where sealing isn't as important. So it may be that you go with a traditional chamfer, maybe that you go with a shoulder with a bevel, or a chamfer with a bevel that's a 30-degree bevel. Something is more towards the horizontal than the vertical, so we get good seating. So number one, think about it for bridges, but not every single bridge. We have to weigh up what is the worst case scenario. We've got to weigh up bad seating versus bad sealing. And if somebody's got a history of caries, then it may be better to have something that seals. And maybe we talk about how we get that to seat down in a few minutes. Second one, what about if we are dealing now with somebody who's got a little bit of mobility? So this may be periodontal disease and it may be general mobility. Two things happen there. Number one, you've got a longer tooth. Very often you've got a longer tooth because the soft tissue shrunk away. What does a longer tooth give you? More resistance retention form. Okay, it's always more difficult to cement and seat something down if you have increased resistance and retention form. So number one, you're battling against resistance and retention form. Number two, the tooth is mobile. So when you come to hit it down, you come to ask the patient to bite firmly together on it to try to seat the restoration. What happens? The tooth just moves out of the way. This acts as a stress breaker. So in fact, you cannot impart the same amount of force to seat the restoration down. So I think it's important at this stage, we just have a brief word about cementation, and especially cementation when we're talking about porcelain fused to metal restorations. How do we cement with a porcelain fused to metal restoration or with maybe a gold restoration? Different when we're talking about ceramics, zirconia and ceramics. We're just talking now metal-based. Number one, we have to choose the correct material. Okay, and I've already mentioned to you that in my view, the correct material is zinc phosphate cement. Why? Well, number one, zinc phosphate gives you the thinnest film thickness. So in terms of seating a restoration down, you're going to get the best possible seating with zinc phosphate. So that's number one. Number two, it is easier to cement multiple restorations with one mix of zinc phosphate. Remember the way that we mix zinc phosphate. Zinc phosphate goes into the fridge, so we keep the powder and liquid in the fridge. We keep the mixing instruments and the glass slab in the fridge. What does that do? That creates obviously a cold environment. When we come to mix the zinc phosphate powder and liquid, it's set by an exothermic reaction. So if we've now got something that's cold, it will slow down the exothermic reaction, and therefore the material that's on the glass slab will not be setting as quickly as other materials, especially materials at room temperature. So it gives us more working time. That's great for me. I can cement 6 restorations in with one mix of zinc phosphate because we've cooled down that exothermic reaction. Think yourself now, if you're going to use other materials, let's say you're going to be using resin modified GIC mixed in a machine, okay, may give you a good mix, but how many restorations can you seat down with that one mix? Usually just one. From time to time, you might try and do 2. And I'm sure from time to time, you've bailed out about halfway through. You can't seat it down, starting to set. And it just becomes very, very difficult to seat multiple restorations. With zinc phosphate, I can seat multiple restorations. Third good reason, it is very strong in compressive. It's very weak in shear. Now you may say, so is that an advantage, being weak in shear? It's an advantage for clear up. So how many restorations do you think have been cemented in this world, especially back in the mouth in the region between the 5s and 6s and 7s, where we've used resin modified GIC and they've waited, the dentist has waited until that material has set and then chips off all the material. What happens interproximally? Very often you can't get the cement out interproximally. Why? Because it's too strong in shear. Now, if you do exactly the same thing with zinc phosphate, we can shear very easy to chip out around the margins and especially interproximally. So how do clinicians get around that problem of getting rid of excess cement interproximally? Because they obviously don't want to leave it there because it becomes a problem for the patient, cleansing, perio issues, etc. So what they do most of the time, this may be you, maybe other people, is they take the cement out while it's in the rubbery stage. So before it's set fully, they push in with a scalar probe and push the cement out before it's fully set. What does that do? That pulls cement out from within the margin. As opposed to shearing the cement at the margin, it pulls it out from within the margin. Straight away, you've got a beautiful, beautiful V-shaped ditch where bacteria, etc., can get in place. And for somebody who's not got great oral hygiene, you're now increasing the risk of caries. So for me, cementation is choosing the right cement to work with for metal and metal ceramics, zinc phosphate. So good seating, we'll get best seating with zinc phosphate. With a mobile tooth, we need to have everything playing in our playing for us. We need to have everything going in our favor for it to work well. Now, the other thing, if you get very mobile teeth, sometimes we need to vent. And from time to time, we may take the restoration, and the technician would normally do that, put a little pinprick, a hole somewhere near the occlusal surface, not on, but somewhere near the occlusal surface. So when we cement this down, the excess cement can come out through that hole. Obviously, we need to plug that hole at a later stage. And we use that technique very often when we're doing Linda and Nyman bridges, okay? The periodontal prosthesis, where you're cementing a bridge onto multiple mobile teeth, that's very difficult to seat down. So if we need a good seat, we're not too bothered about the seal, then we're going to use a shoulder or traditional chamfer. What about the next one? What about where a good seal is important and you're not too bothered about the seat? So this means that we're sealing well, but from time to time we may need to go in and adjust the occlusal surface for the occlusion, for the bite, once we've cemented it in place. But we've got a good seal. For those instances, when are we going to choose that seal? It's important if we're dealing with somebody who's got caries. I've been dealing just recently with a patient who was in a road traffic accident. As a result of that, this patient has got a mental age of about 5 or 6. So the patient's 28 years of age, but has been had a brain injury, has now got a mental age of about 5 or 6. Guess what? He won't clean his teeth. He can't clean his teeth. He forgets. His parents like to give him some sweets and some snacks so that he can keep himself occupied, etc. As a result of that, he's getting caries. And he started off with class 5s, and we've been around and we're trying with the hygienist to improve the oral hygiene to get him working that way. The restorations are class 5s. We put in composite. We're now putting in glass ionomers. Ultimately, several of them are still leaking. Several of the teeth are breaking, and we're having to go to crowns. And for the crowns, the margin of choice here with high caries is absolutely going to be one that seals, one that goes subgingival and one that seals. And that will be my VertiPrep, which I'll come on to a little bit later. And then we have our final one, which is probably most of the work that you do. It's the average seat and seal, when we will go back to our traditional workhorse. And our traditional workhorse will be probably a traditional chamfer margin. So let's look at these margins in a little bit more detail. The shoulder, okay? When do we do a shoulder? I have to tell you that I don't. I can't remember the last time I ever did a shoulder preparation. Maybe you wish to do a shoulder with a bevel on it. That's different. That's a shoulder bevel. But a pure shoulder, I can't remember when we last did one. I can't see the reason for doing it. Okay, shoulders do not seal very well at all. They seat well down, but chamfers also seat. We've mentioned that if you're going to use a ceramic margin, then ceramics do not do 90-degree internal line angles. So you're better off doing a chamfer. So let's look at chamfer margins, okay? We throw shoulders away. Chamfer margins. We've mentioned that you have to go and find the exact thickness of the burr. So whatever you're wanting to do in terms of the chamfer margin, in terms of thickness, we have to find a burr that's either twice as thick, or we use a burr which is the correct thickness, and then we have to get rid of the lip. Okay, so these are the two alternatives for doing a chamfer. So if you like, if I'm wanting to do a 1.2 millimeter chamfer at the gingival margin so that my technician has got adequate space for ceramic, I need to use a burr which is 2.4, let's call it 2.5 millimeters wide at the cutting tip, and I prepare whereby the burr is half on and half off. So that's how I understand if I've cut the correct amount. I can't really go in with rulers and start to measure how much I cut. So the cutting becomes very much a visual thing, measuring. And if I lined up 100 dentists and asked them to go and put two lines next to each other, 1.2 millimeters apart, what do you think will happen? If we went to measure them, some would be probably 0.5 apart, some would probably be 1.7 apart. The problem is we do not understand what 1.2 millimeters looks like. Therefore, we have to have references. The reference comes from understanding the burr. And if I was using a shoulder burr, remember we don't do those anymore. But if I was using a shoulder burr, I would use a shoulder burr with the correct width of the shoulder I wanted to cut. So if I wanted to cut a 1.2 millimeter shoulder, I'd use a 1.2 millimeter shoulder burr. That's fine. And we keep on prepping until the shoulder burr is encompassed, if you like, is within the long axis of the tooth. So it's now flush. The edge of the burr is flush with the margin. However, for chamfers, a different shape. the chamfer has a round cutting edge, and therefore we create the correct chamfer by cutting only with half the burr. So a 1.2 millimeter chamfer means a 2.4 millimeter cutting tip. A 0.5 millimeter chamfer round onto the mesial, distal and palatal. 0.5 for a metal finish line means that we have to use a 1 millimeter cutting tip. So get the magnification loops on, get the digital calipers, and what we have to do is measure, and whereabouts do we measure? Okay, here we have burrs that have got a 6-degree convergence angle to them. So that means that they're going to be wider here, thinner there. So with tapered burrs, whereabouts do we measure? Whereabouts do we measure the cutting tip? This is important. So with our loops on, we can see quite well here that we have a straight surface, a flat side, and around about there, we now start to curve. That's where you measure. Okay, so it's as the flat surface, flat side starts to just curve round to the curved cutting tip. That's the point that we measure. Okay, the interface between the flat and the curve, just there. And that needs to be twice. Our reference point is when we start to prepare, the whole burr is off the tooth because we've not really created anything yet. And we keep on prepping until our reference point is that the burr is half on the tooth and half off the tooth. We now know we've cut the right amount. Now, what happens for areas where maybe we don't have the space interproximally to cut, or you don't have a big enough burr? So in those situations, we need to use the chamfer burr as we would a shoulder burr. So we have the chamfer cutting in, creating a margin so that the whole of the burr lies within that margin, as we would do with the shoulder. The problem with that is, of course, that creates a lip. There's the chamfer burr, and that creates a lip. And our problem with that lip is twofold. Number one, when we take an impression of it, because that lip is very often enamel, it's not as visible, it's translucent, so we can't see it very often. That's why it's essential when we look at impressions that we use retraction cord or gingival rotary curettage or something to expose that margin. Do not rely on light body and putty to get impression material past the margin if you've got a lip, because it won't happen, you won't see it. So number one, when we take an impression, then that impression will be cast, and what will happen to that very, very thin lip on the stone model? Usually it fractures off. When that lip fractures off on the stone model, and it doesn't need to be circumferential, it could be just a lip just somewhere where you've not quite seen it. If that lip then fractures off on the model, technician will be working to a different margin than's actually in the mouth. So what happens then? You come to seat the restoration down, and guess what? It doesn't seat down. There's a reason somewhere around the restoration, there's a little bit of enamel that is propping the margin up, and you end up having a margin that's open all the way around. So we have to get rid of that lip. Three ways of getting rid of that lip. The first thing is to put your burr on horizontally. So instead of taking the burr and burring around like this, we put the burr horizontally, and we basically go from mesial to distal with our burr horizontally. For this, we'd use a diamond finishing burr, a red stripe. And again, this would very much be in a speed increasing handpiece so that we've got true feel, okay, and we've got more control. It's cutting as we want it to. That's number one. Number two, you can get something called end cutting diamonds. And these are burrs where the surfaces, the sides are smooth, no cutting, no diamonds whatsoever. It then has a beveled tip. So we have bevels and then a flat bit in the middle. Only the flat bit in the middle has got diamonds on it. So when we put it onto a margin, it will not cut axially, it will not cut the soft tissue, it will just cut that lip. And we basically just run the end cutting diamond around on the lip to get rid of it. Third way, the old way, probably still the very best way. Gingival margin trimmers, hand instruments, hoes, chisels. Get rid and get a very, very smooth margin with using hand instruments. but one way or the other, we have to create a smooth margin. So I'll go back to it. Final thing, either use a burr, which is 2 times the size of the margin you want to cut. Do the margins with the speed increasing. By all means, use a turbine to grossly cut it, but then finish the margins off with that speed increasing. Or if you don't have the correct burr, use a burr which is smaller, realize you've created a lip, and then get rid of the lip. And just a nice example of a chamfer. This is for an all ceramic zirconia crown, and we've got a 1mm chamfer all the way around into the lab, and the technicians produced a ceramic restoration, simple ceramic restoration, which is then cemented in the mouth. So that's our chamfer preps. Next one is the shoulder or chamfer with a bevel. Okay, now let's look at bevels. Okay? When do we think about bevels? What does a bevel do? A bevel helps to seal. So if we have a shoulder or a chamfer like this, by putting a 30-degree bevel on, we are making that margin seal a little bit more. Okay, it won't seal as well as a 60-degree bevel, but it will seal better than the 90-degree margin. So again, we're into compromises. Okay, so this is something now, the shoulder with a 30-degree bevel, which seats well, but also seals a little bit. And we've got these different bevels that we can put on. The 30-degree bevel seats well, seals a little bit. 45-degree bevel is halfway between the seat and seal. Average seat, average seal. And then when we go down to a 60-degree bevel, we're now going down so that the angle of the margin is more in line with the axial surface, the long axis of the tooth, and therefore we're getting better sealing but more difficult seating. So why do we use these things? Usually the bevel needs to be a metal bevel. So we can see here, we've got a chamfer with a bevel running around it for a better seal. So this is an area where I want to compromise. I want a metal margin, but I want to have a better seal. We can't do bevels with ceramics. So bevels are only there for metal. Okay, and that could be gold. So you go back to some of the classic 3/4 crowns, gold onlays, 7/8 classic crowns, and a lot of those margins will be shoulder with bevels to create a better seal. So we get the sharp internal line angles of the gold to give us good resistance retention form, and then we're sealing around the outside. So most of my metal ceramics, especially in the back of the mouth where it's not going to be visible, are done with metal margins. Metal margin seals better, metal margin fits better, and for that I need a chamfer or shoulder with a bevel. And now we're going to come on to the last bit of the presentation, which is going to be the VertiPrep. So there's a lot of talk the last sort of 5-6 years on VertiPreps. I must admit I use them a large amount of the time now. The VertiPrep was the original knife's edge, marginless, feather edge preparation that was advocated many, many years ago. Went out of fashion, as you're aware. Lots of things go round and round, come back into fashion. So the VertiPrep now has got fashionable. And why is it coming back into fashion? It's come back into fashion because we're now milling restorations as opposed to casting them. So it was shown many, many years ago with the margins, we went for cast margins, the PFM and the gold restoration. But if we try to cast to a long, thin margin, remember our VertiPrep is a long, thin margin. If we try to cast to a long, thin margin, then what happened was that the metal during the casting process got a little bit, lost its heat, cooled down a little bit as it was being cast into a long, thin section. And at the end of the day, the metal didn't reach the end of where the restoration should be. So they all came up short. As they came up short, they came up rounded. So one of the problems with the original VertiPrep, marginless preparation, was that it was difficult to get the casting to go to the end of your preparation. So they were usually short. This has been completely negated now by the milling techniques. So we're using most of our restorations, we're milling. We can mill, obviously, zirconia, EMAX, we can mill PFMs down if we have the correct alloy. So the VertiPrep has now come into existence. And what is the VertiPrep? The VertiPrep is basically, if we look at the 2 and the 3 here, it's basically a margin that goes subgingival, but there's no margin. You can't see it. So what we're doing is we're taking away the bulbosity of the tooth, and we're creating something that has convergence. And remember, if these are going to be zirconia, then we're looking at maybe 15 to 20 degrees convergence, something that goes underneath the soft tissue, but does not have any margin to it whatsoever. Again, we're just going underneath the tissue and creating a finish line. The burrs that we're going to use for this are either, there's a burr out there called the bat burr, and those have been made especially for this preparation, and it's basically a burr, so it's a fine needle burr, okay, very thin cutting tip, fine needle burr, where the last part of the burr is blank. So it actually cannot cut a margin because the tip of the burr is blank. That's called a bat burr. Other ones that you can create your own bat burrs, and I'm sure you have over the years, cutting through old PFMs or old gold crowns to remove them from within the mouth. Very often you'll cut with a standard, maybe chamfer, small chamfer burr, so you can get a flat plastic in, twist, and the crown come off. And the tip has been denuded of any diamond particles. So you end up with a blunt cutting tip. Okay? Keep those. Really, really important. Those are 2 uses. Number 1 use for those blunted tips is the VertiPrep. Number 2 use, gingival rotary curettage. They're great for restorative dentists to do crown lengthening with, to do gingivectomies with, so that you do not damage the tooth. So the blunt tip is placed onto the tooth. You then go round and round and round. You cut the soft tissue away, but you do not damage the tooth. Likewise, if you use that same burr underneath the tissue, you'll cut out the inner epithelial lining when you're doing a VertiPrep, which is part of the technique. You'll cut the axial walls, but there should be no margin there whatsoever. And there's our marginless preparation. So when we do this, expect to see your impressions looking a little bit different. Here's a case, and we'll talk about what cases they're ideal for in just a second. And we look at our 2 crowns here with vertical preparations, and you see there's no margin there. There's no margin whatsoever. So when do we use these? As we mentioned, when we want a good seal. Okay, number 1. Number 2, because we're not cutting as much away at the margin, these are therefore more minimal. So we'll use these wherever there isn't a contradiction to it, because they're more minimal. Number 3, especially good when we're dealing with post-crowns. Really, really good. Why? Because we've been shown from some of the studies that we can go deeper subgingivally with a vertical margin than we can do with horizontal margins. And if we can go deeper vertically, we can create a greater ferrule. And the ferrule is, as you well know, one of the most important parts of the long-term success of restoring an endodontically treated tooth. Especially a tooth that's got a post in place, we need an absolute minimum of 2 millimeters of ferrule. The more ferrule we get, the greater the longevity of our restoration of that root-filled tooth will be. So I want to get as big a ferrule as I possibly can. And that means from time to time, I'll go 2 millimeters subgingival with my margin. So in a case like that, I'll have a 4 millimeter ferrule, which will lead to a much more successful end result. So this paper came out in 2013, and it also looked at some of the soft tissue aspects of using these vertical preparations. So although the paper does not talk about it, it talks about the biologically orientated preparation technique, BOPT. It uses a vertical margin in its preparations. So just before we go about that, let's look at some background. We've also seen since then that if we place a margin subgingivally and we change the emergence profile, that will have a bearing on the soft tissue. So this concept is a very important concept for you to get. The average, we look at average thicknesses of enamel today. Okay, let's look at the inclination of an anterior tooth. Okay, the inclination of the anterior tooth, the enamel cap comes out compared to the long axis of the tooth at an angle of about 30 degrees. So the emergence profile of the tooth to the long axis is about 30 degrees on average. Now, if you can imagine, you have a tooth there with the correct angulation. Now let's look at two other teeth. Let's look at the tooth which is proclined and the tooth which is retroclined. Whereabouts is the soft tissue on the tooth which is proclined? Think about it. You see many. With a proclined tooth, usually the soft tissue is higher. Usually you might have a very thin biotype with that. Now, what about the tooth which is retroclined? Whereabouts is the soft tissue? The soft tissue is usually further down, more incisal, and it's usually thicker. We have a thicker biotype. So it appears that there's many factors which influence the biotype and the positioning of the soft tissue. One of those factors is the angle that the tooth emerges from underneath the tissue. So, question, what do you think would happen to gingival levels if we changed the emergence profile and we went from the average 30 degrees to less, to 15 degrees, to 0, in some instances to a negative minus 15 degrees? What do you think will happen? Well, the answer is the soft tissue will start to grow down. It will grow down because the soft tissue is not being held up. If it's being held up at that angle, we change the angle. Okay, look at the tip. Here's my soft tissue. Change the angle. What happens to the soft tissue? It rotates downwards. It falls down into position. So this particular paper was looking at doing subgingival preparations. We'll come back to how deep in just a second. But then modifying the emergence profile. The emergence profile so we could get tissue to come down or tissue to actually go up. What happens to a tooth if we create an emergence profile which is steeper? The soft tissue will go up. So the dental technician now can place his margins, okay, up and down. This is the important part about the VertiPrep, is the technician chooses where the margin can be because there's no margin. There's no margin to work to. So the technician chooses the level of the margin, and he can also choose the angulation of the margin. And by choosing the level and the angulation, you can get soft tissue to start changing its profile. So we can get teeth that have got recession defects to actually grow down. What we get, of course, is a long junctional epithelium, but it's a healthy long junctional epithelium as the soft tissue just grows down. As we've been doing this, as the science is evolving here pretty rapidly, these margins have been placed deeper underneath the tissue. Now, you know that if you place a margin deep under soft tissue, okay, we have something called the biologic width, okay, which is about sort of 3 millimeters-ish. You've got a millimeter of gingival crevice, you've got a millimeter of epithelial attachment, you've got a millimeter of connective tissue attachment on average, and then you hit bone. So you've got about 3 millimeters there. If you go and put the margin within that first millimeter gingival crevice, then in theory, we should, with good cleaning, keep a good, healthy periodontium. You go below that pocket, so you go deeper and put your margin deeper than 1 millimeter. What happens now? We're interrupting the epithelial attachment, and usually you'll get one of two things. We either get a little bit of recession or we'll get a little bit of inflammation, one of the two. The deeper you go into the connective tissue, the more recession or the more inflammation you'll get. And we've always said it's because we've invaded the biologic width. But just a point, we've invaded the biologic width for the last 30 years during these scientific studies with what sort of margin? Vertebrates haven't been around. So we've been invading with horizontal margins. What do we know about horizontal margins? We've been invaded by shoulders, we've been invading by chamfers. Horizontal margins do not seal. What's the opposite of not sealing? Well, how can we say it in a different way? They leak. So maybe it's not the physical positioning of the margin, maybe it's the sealing and potential leakage of the margin, which is creating the problem. So then we came along with this particular paper and with similar papers since. And these have been using margins, vertebrate margins, up to 2 millimeters subgingival, where you would expect to see, in some of the cases, either recession or inflammation. And there's been the tissues look absolutely pristine and healthy. But we are leading to believe that we can place margins deeper subgingivally if we use a vertical margin as our preparation. Hence, the vertebrate now becomes a really important margin for this tooth. For the margin for the root-filled tooth, post-crown tooth, where we want a greater ferrule. The margin where we want to change soft tissue. The margin of choice when we want to do a more minimal preparation and not have to take 1.2, 1.5 millimeters away from the gingival margin. So let's finish with this particular case. And it's a case that illustrates the principles of the BOPT technique. So we have a lady that comes in with 6 anterior crowns. The anterior crowns obviously do not look very nice. We can pick holes in them. From a smile design point of view, the golden proportion is incorrect. The canines look too bulky. There's many, many factors. We now go and look at the lips, get the lips retracted out of the way, and we can see the other problem that we're facing is our teeth are long and thin. Okay, and we've got recession. So how are we going to fix this case? We're going to fix this case 2 ways. First of all, we look at the smile and we can make sure that these teeth are in the golden proportion. We can also start to give better ceramics in place, so these things look a little bit more translucent. We can start to create the illusion of slightly wider teeth, because in this instance, we either need to make the gum margin come down, or we need to make the incisal edge go up, or we need to widen in order to get the correct width to length ratio. You know that the correct width to length ratio is around about a 75 to 80%. We know that the width of 2 centrals to the length of 1 central should be 1.6 to 1. So we know all these factors that create the ideal smile. Okay, all down in the literature. We talk about it, we lecture on it all the time. So what am I going to do in this case? How can I bring that soft tissue down? Can I make the incisal edges shorter? Well, not really, because this is a reasonable position for those incisal edges, the amount of tooth tissue that she shows when she smiles. So I have to now bring that soft tissue down. How am I going to do that? Okay, several ways. Number 1, we can do some periodontal connective tissue grafting. And we can stitch some gum into place. Number 2, we can use orthodontics and we can pull these teeth down. And when we pull the teeth down, the gum margin will come down with it. The alveolus comes down, the gum margin comes down with it. And eventually, as the teeth become longer, we cut them off so they stay in the same position, but the tooth gets shorter, the root gets shorter, but the soft tissue appears to come down. That's number 2. Number 3, we can use some pink porcelain. We can maybe go and try and mimic the color and the effect, the stippled effect of the soft tissue, put that into our crown. Number 4, in this case, we're going to use the BOP technique, and we're going to bring that soft tissue down by putting margins further underneath the tissue, by changing the subemergence profile, I'm going from that 30 degrees to something that's flat. And we're going to do that by taking these crowns off, taking the margins there, which are deep chamfers, and putting a long bevel onto the deep chamfer. So in effect, if this was a new preparation, a new tooth that I'd be preparing, I'd be doing a vertiprep. However, these are old restorations with heavy margins, with shoulder and chamfer margins. You're going to see this all the time. How can you create a vertical preparation if you've already got an existing horizontal margin? The answer is, on that horizontal margin, you're going to go and put a long bevel. And you're going to go and make that long bevel 60, 70 degrees, and you're going to therefore have a chamfer or shoulder, which gets smaller with a long bevel. And we go towards the vertical margin. So not your true classic vertiprep. The long bevel, however, becomes the modified vertiprep for existing crown work. So we go through our standard protocols: mounted study casts, diagnostic waxing, prototypes, preparation guides. We take the old ceramic, the PFM crowns off. We now start to prepare with enough space for our new vertipreps. These are going to be zirconia crowns. And we end up initially taking the crowns off and then beveling. This is the important part. We now bevel underneath the soft tissue. So you can still see that we've got the old shoulders, mesially and distally. I'm not trying to bring the soft tissue down mesially and distally. I'm just trying to do it labially. But where we've now gone into our deep chamfer or shoulder labially, we've placed a bevel. You can't see it. This is going right underneath the tissue. One of the whole points of the long bevel of the vertiprep is you can't see the margin. It fizzles out to nothing. And again, this is now putting one of those bat burrs, modified yourself, or you buy the bat burr underneath the tissue. As it goes underneath the tissue, the actual tip of the burr does not cut because it's blunt, but then the axial wall. So the blunt tip is about a ½ millimeter to 1 millimeter deep. And then the rest of the axial wall starts to cut. We get our prototypes, we reline with our prototypes. We now have long beveled margins underneath the tissue. And the technician is now going to make some zirconia vertipreps. These will be 0.1 of a millimeter at the gingival margin, 0.1 thick. That's as thin as we can get the vertiprep. And those margins will now be at different levels. So here's my new ceramic restorations. We've done a few other things. We've moved the marginal ridges out to make them appear wider, the appearance of wider, shorter teeth. So for that, we've got several tricks that we can use. The first trick is to move the marginal ridges a little bit further out so we create more space internally on the labial surface. Second trick is to flatten the labial surface so the light bounces back at you when you're looking, and therefore it looks wider. If you have something that's very convex, then the light hits and scatters to the side so it looks thinner. Next thing is to put horizontal. You can see horizontal lines here, and it's important that if somebody is rather wide, that they don't use horizontal lines because that makes somebody look wider. So for instance, somebody like myself, who's a large gentleman, I would always wear stripes and not hoops. Stripes make people look thinner, and therefore if you put vertical texture onto a tooth, it makes the tooth look thinner. You put horizontal texture onto a tooth, it makes the tooth look wider. So what the technician is doing here is, as he's trimming and shaping, he's trimming and shaping, not going from gingival to incisal, but by going from mesial to distal. So his burr lines are going across the tooth, creating horizontal lines, not vertical lines. Color-wise, we're putting a little bit more color into the gingival third, a little bit more translucency into the incisal third. So the tooth is this length, but the actual tooth that's the correct color, that's the same color, is less. So all these effects are going towards making teeth that look shorter and wider. plus the vertipreps and BOP technique will bring the soft tissue down. So this is now, we're in the mouth, and this is the day of cementation. Soft tissue, this is a day of review. This is 1 to 2 weeks later. The soft tissue is coming down. It's still a little bit on the reddened side. But from here, we've managed to get our soft tissue to come down by a good millimetre, millimetre and a half. And we've created a long junctional epithelium here. And that's been purely because we've changed the angle, the emergence angle, emergence profile, to allow the soft tissue to start to come down. So the BOP technique is a really, really important technique now. I'm going to finish on this case. It's an important technique for creating margins where we don't take as much tooth tissue away, creating restorations that are more retentive when we want them to be, to allow us to manipulate soft tissue more. So this goes into the vertical margin and BOP technique. So I'm going to finish that now. I thank you for watching. I hope that you found it of some use. Margins and margins design, like everything in dentistry, the more science we get out there, the more it gives us further questions. So like everything in life, we thought we knew it all, and then the deeper and deeper you go into the science, it throws up more and more questions. And an important one has been fairly recently is whereabouts should our margin be placed in respect to the soft tissue and the biologic width. And we've not got the answers yet, but it appears that we can be going deeper if we use the correct margin. So thank you very much for listening. I can see that we've got some questions to ask, so I'm going to go to some questions and we'll see what the questions are. Okay, I'll read out the questions, guys, so that we can answer them all. First one, anonymous. Thank you for your lecture. Does the inverse relationship between seat and seal also apply to the bonding luting agents? Yes, it does. It does in the fact that you are maybe changing the bonding or luting agent depending on whether you're going to be seating or sealing is the most important part for you. If you're going to use a horizontal margin, then that's going to be easy to seat. So in theory, you could use a cementation agent, which is thicker. If you're now going to go and use the opposite, a vertical margin, you know that those are going to be difficult to seat down. And therefore you need to go to a cementation agent, which is thinner, so it's easier to get out. So I hope I've answered that question there for you. Next anonymous one. Would a shoulder margin with a rounded internal angle work for ceramic? Yes, that's what a chamfer basically is. It's a shoulder with a rounded internal line angle. So that is in fact basically a chamfer. I just find shoulder margins easier to be developed. They are, okay? And one of the ways that we try to improve tooth preparation, we do multiple tooth preparation courses for people, is that the shoulder is very easy for people to cut because they can feel that they're digging into the tooth. They have a vertical stop and they feel that they're digging in. So it's quite easy or easier to cut a margin which is at the same height all the way around. You get more tactile feedback. With the chamfer, because you're not cutting in, you don't have the same tactile feedback. So what do we teach for those people who are struggling? Number one, two-handed tooth preparation, direct vision, far easier. You're not relying on that tactile feedback. Number two, speed increasing handpiece. Number three, magnification. We talked all about that. Okay, the other thing to do is decide on the size of your chamfer and cut initially a shoulder which is half the size. So let's say you're going to do a 1 millimeter chamfer. Cut a 0.5 millimeter shoulder all the way around. Now put your chamfer burr onto the shoulder and go around, and you will modify that shoulder so it becomes a chamfer. The shoulder will go a little bit deeper, so you might want to put the shoulder at gingival level all the way around, the small shoulder, put your retraction cord in, and then go around and around and around with the speed increasing handpiece with the chamfer burr, and you'll find more tactile feel as you create the chamfer from the shoulder. Next question, Nicola. Always find abrasion abfraction lesions tricky to prep. Any tips? Yes, so abrasion and abfraction lesions are difficult to prep because you've got this subgingival, first of all, but you've also got this undercut. So the way in which you should go around that is always, number one, is bond, either with normal bonding agents or go and put some GIC, resin modified GIC in there, but always place, I'll say an inverted, core. So always restore first and then prepare. Don't try and prepare with the abfraction lesion already in place. Restore it first, either with a temporary material or with a definitive. Okay, ideally definitive, go and bond it, etc. Get a nice bonded composite in place, and then put your margin, obviously, at least 1 millimeter below the level, the margin of your bonded composite restoration. Ling, a vertical margin, is a knife's edge margin? Yes, it is the same. It is absolutely the same. It's just the fact that how we get it, how the technician makes it now is different. It's not casting, it is now purely a milled margin, but it is exactly the same. This is the same ideas, just going round and round and calling them something new. Okay, but that's exactly the same link. Next question, Toshiba. Any tips for cementation in case of vertipreps to avoid excess cement? This is one of the most difficult parts of doing the vertiprep, and you need to use a very experienced dental technician who is used to doing this, because straight away we're doing a milled restoration, so we're now dialing in to the software the amount of cement space, and we need more cement space for a vertiprep than you do for a traditional margin. Why? Because the cement will not come out as easily. Why? Because you're using a 0.1 millimeter margin, thick. Therefore, if we use too much force, the hydraulic pressure of the cement coming out from underneath, that can cause the margin to fracture. We've had all these problems. As we've gone through it, we've had all these problems. So we need to have a greater cement space. Also, make sure you're using the correct cement. And ideally, if we're going to go cemented, it's zinc phosphate. Especially if we're going to go subgingival, then I'll be using zinc phosphate for that. So cementation is difficult, down to technician. Okay, so it's down to the technician to give you more space. So these things cement down more easily. It's like putting in more die spacer, if you like. Ling again, when dealing with vertipreps, no margin, could it lead to over margin crown? Then we want to seat the ceramic crown. Could this lead to crack in cervical? Absolutely, yes to both of these. So the first thing is with the over contouring of the crown. Remember, the crown comes out at that 30-degree angle most of the time. So if you put a 0.1 millimeter margin in place with the correct angulation, that's similar to putting the enamel cap in place. So as long as you're using a good technician who can use a thin margin, it will not lead to an over contoured crown. Second part is, can it lead to a crack in the cervical aspect? Absolutely, yes it can. And therefore we have to be using an experienced technician, a technician who's used these margins before. I remember doing the first ones with my technician, a very experienced worldwide technician, doing my first case about 3-4 years ago. And the first case I did, I had to do it 3 times. They came back 2 times, and there's no way I could get them seated down with cement. So it does need a lot of work, more technically difficult and challenging to do. Next question from Katrina. Which margin do you use for overlays and tabletops? For those, I use a light chamfer. We just need to make sure that the margin is away from any occlusal contacts, but I'm quite happy with a 0.5 millimeter chamfer for these. It gives a nice balance between seat and seal, but also your onlays, overlays, because we're using an adhesive cement, they don't need to actually fit quite as well. because we're using quite a thick cement. Very often we're going to be using a cement which is the actual composite itself, a heated composite. So we need things to flow out. So traditional chamfer is fine for me. Thank you. Nicola, very good perspective. Thank you. Thank you, Nicola. Tran, great presentation. Are you taking working impressions on the same day as the VertiPrep? We can do. So for anteriors, no. For anteriors where we're looking at major aesthetics, we're putting our prototypes in and we're leaving our prototypes for a period of time. In the highly aesthetic case, we can start to change the emergence profile of our prototypes, taking them on and off several times. This is a very, very elaborate technique, but if we've got a patient where aesthetics really matters at the front, we'll leave our prototypes on for 3 months. We'll take them on and off maybe 3 or 4 times and just change the angle, and that will get our soft tissue to come down or go up until it's just right. Now, that raises a good point. How do we then get that same angle when we come to do our definitive restorations? Well, what we have to do is obviously take our impressions, but then take an impression of the margin of the crown. So we have a little small putty, and we put into like a Dappens dish, mix some putty, and then take the margin of the crown and push the margin of the crown into the putty. So the technician can actually understand, can see, can put something in there, whether it's going to be PMMA, into there, and can then scan the margin. So he has the exact shape of the margin. So very, very complex. Posteriorly, in non-aesthetic areas, yeah, I'm dead happy to go and take my impression at the time of my prep, so I don't need to leave it. So just stop the bleeding, because remember, with the VertiPrep, you will take out the inner epithelial lining, so it will bleed. Stop the bleeding, take an impression. Okay, if you have an open sulcus, you don't need retraction cord. If you have a closed sulcus, you'll need retraction cord to get into there, take it out, and then take your impression. Okay, next question, Katrina again. Where can we buy the bat burr? You'll have to look in your directories, guys. Just look in your directories for bat burrs, or as I mentioned, create them yourself. Thank you very much, Wari, thank you. Albert, hi Paul. What was the VertiPrep burning? Again, bat burr, B-A-T, bat burr. Katrina, which lab do you use for VertiPreps? You give a hands-on course with VOP technique? Yes, Katrina, we do the VOP technique, VertiPrep technique, as part of our Phantom Head course, our operative PG certificate and PG diploma course that we do through Tipton Training and the British Academy. So all that is on our website. If you look at Tipton Training website, you'll find all that. It's the PG cert in operative dentistry, where we do the Phantom Head work. And lab, I use Marco Bacisa. He's down in Cornwall. So you have to look up his name. He's an individual technician, Marco Bacisa. Okay, let's continue. Can I explain a little bit more about margin design and emergence profile? Yeah, I've covered it, but again, what I'm trying to do is suggest that if my margin comes out at 30 degrees, the average, your gum will be in a certain position, your gingival margin will be in a certain position. If you change the emergence, this is the sub-emergent profile. Change the sub-emergence profile, okay, and what will happen? The soft tissue will change position. So make the sub-emergent profile steeper, so it comes out at a higher level like this. This puts pressure on the gingival margin. The gingival margin will go up. Soft tissue will go up. Come out flatter, sometimes even negatively. So you have like a little concavity subgingivally. The soft tissue will come down into it. Next question. Okay. What do you think of bevels for overlays? Katrina, ceramics use bevels with ceramics. They just don't do them. Alex NSK, thank you for tips and training arranged today's webinar. Alex says these are unprecedented times. It's a pleasure working with you and the team NSK. Thank you very much, Alex. We'll get through this together. This is from Alex at NSK, guys. If you wish to get in touch with NSK, they can help with handpieces and they can give you whatever advice you need on the speed increasing handpiece. Nicola, thank you. Sarah Aziz, thank you very much for a great lecture. Upper central tooth, which has some degree of gingival recession. Patient has high lip line, does not wish to have surgical gingival perio replacement of low gingival margin. Where would you put the prep margins, please? Good question, Sarah. So first of all, take the crown off. That's number one. Number two is if there's, presumably you've got a crown there, it's probably got a shoulder or a chamfer on it. So as I've mentioned, now do a long bevel underneath the tissue. Go 2 millimeters underneath the tissue with a long bevel. Okay, next thing to do is go and take that prototype, reline the prototype underneath the soft tissue. And now if we've got a 30-degree angulation, subemergence profile, change that to 0. So it comes out underneath the tissue flat. That's its sub-emergence profile is flat. And then at the gingival margin, it starts to come out by 30 degrees. So it's the sub-gingival, the sub-emergence profile, which is the important part. Put that in place and then just let the soft tissue do its thing. And the soft tissue will slowly start to come down. Now, if it doesn't come down enough, then you have to change the sub-emergence profile more. And that can mean going from something which is totally vertical to something which is negative. So in those situations, if I've got 1 to 2 millimeters of temporary material which is underneath the tissue, I'll take a round burr, a small round burr to the margin, and I'll create a little hollow just at the margin. So this is still subgingival. So I'm creating a hollow, okay, a concavity underneath the gingival margin. And again, that will allow more soft tissue to creep down into it. So we will wait, we'll take the temporary crown off and on, off and on, and adapt it until we get the correct position. Obviously, we can't bring things down 5, 6, 7 millimeters. Okay, the maximum we're going to bring something down is probably a couple of millimeters. So it all depends on nuances. I hope that helps. Preferred cement for cementing zirconia crowns and why? I like zinc phosphate. It's going to be near the gingival margin. Then I'm going to go to a resin modified GIC. And the difference is that zinc phosphate, it can stain a little bit. If I'm deep underneath the tissue, 1 to 2 millimeters, I'm not bothered about that staining. However, if I'm supragingival, equigingival, and I get a little bit of recession, that staining can be important. And you'll find that a resin modified GIC does not stain as much. Angela, I often worry I'm removing too much tooth structure and usually end up under preparing. Well, the VertiPrep is a great one for you then, if you under prepare. I think there's been an awful lot over the years of hype about over preparing. Okay, if we look at statistics and studies, we look at, and I'll ask you the question, what percentage do you estimate, if you were talking to your patient, of crowns that go non-vital, or teeth that go non-vital after crown work? Now, most people will say probably 20 to 25%. It's important you look at some of these studies. And the studies have actually shown us, if they're done properly, that that percentage is more in the region of 5%. Okay, two things has happened. These are old studies that give you the 20 to 25%, and they're done without any dentine sealing. Nowadays, we're sealing the dentine. And as you well know, it tends to be more bacterial threat that kills pulps than physical. I'm not saying there's no physical threat at all from the burr and heat, etc., but it's more bacterial. So take the bacterial element out and seal the dentin, which we do to every single restoration before we go and take an impression. Second part is that we need to be using the correct burrs, and we need to be using lots of water. We need to be thinking about using the correct local anesthesia for infiltrations and using one without vasoconstrictor so that we don't cut off the blood supply to a tooth pulp that's been damaged. But the most important thing to get the stats right is to go and vitality test first. So the studies which show 20 to 25% of cases of teeth going non-vital after crown preparation, no vitality testing done first. And if there's no vitality testing, guys, we don't know. We're probably prepping teeth that are dying or already dead. So we have to vitality test. And it's a French study that gives you the 5%. And it's a really good study that vitality tested, first of all, and then looked over a 10-year period of the number of teeth that went non-vital. And it was just around about 5%. So I can't tell you how you should be getting over this problem of not cutting enough away. But if it's because you're worried about damaging the tooth, yes, of course, we know. We take more tooth structure away, we damage it more. But it's percentages. If you don't take enough away, the result will not be correct. If the result's not correct, you're going to have further problems. So use a good technician, a good lab, understand the spaces that you need to cut the correct restoration, get a technician to give you a preparation guide, and cervically especially start using this VertiPrep. And all those things should go towards helping you cut the right amount off. Sharon, thank you for a great presentation. Would you do provisional restorations in stages in order to keep changing your gingival level emergence profile? I think I probably said that. Yes, we would do. We take them on, take them off, change that emergence profile until we get the position we want. Then we have to copy the margin that we've created into the final margin. And we have to take an impression of the crown margin. Okay, so that's not the impression of the margin of the tooth. The actual temporary, we take an impression of the temporary out of the mouth. We take that temporary, we put it into an impression. Okay, next one. Francis, what type of temporary crowns? All my temporary crowns, I don't like to call them temporaries. They're made by the lab. I call them prototypes. So they're all laboratory made from a diagnostic wax up, first of all. But if you're not using that, you can always go and take an alginate impression, first of all, and then use Luxatemp. I really like Luxatemp. So my prototypes are shell prototypes, which are then relined with Luxatemp. You can always go and do with an alginate and put the Luxatemp into the alginate, put it back into the mouth, and then trim. Nitam, while final cementing the crown after the trial, if a patient feels it's a bit high, then what do you do to remove the final cement? So if the crown's already cemented in place, you can't, take it out. Okay, we have to just polish in the mouth. Sometimes you need to understand that when you put a crown in place to try it in, to look at aesthetics, to look at occlusion, etc., that crown should be a loose fit. It's important that you understand the lab techniques here. So if you don't have a loose fit, if you have a tight fit, then two things can happen. Number one, you can damage the margin of the crown trying to get it in and out. Number two, you can't get the crown in and out because it's fitting too well. So there needs to be a looseness. So there's no correlation between the fit of a crown prior to cement to how well it should fit after. So in fact, make sure you have a loose fitting crown in the first place before the cement. So that means having the correct amount of die spacer in place. Okay, Cleopatra, next one. Thank you very much, Dr. Simpson, always a pleasure. Thank you very much. Nitam, thank you very much. Andy, thanks for the lecture. Is retraction cord needed for secondary impression of the VertiPreps? Not essential. Okay, so retraction cord. Retraction cord is just a way of getting impression past the margin. Okay, so that's what we've used. We've done margins in the past, And it's been so important that the technician margin is, so he can work to it. Guess what? VertiPreps, no margins. That's number one. So number two, there are also other ways of getting impression material into the sulcus. So number one, cut the sulcus away, called gingival rotary curettage. Number two, open the sulcus by, again, taking out the inner epithelial lining. So there's various ways, but it's not as important to get an impression past the margin because there's no margin. So it's not as important with the VertiPrep. Sarah, thank you very much. Naya, thank you so much for a great lecture. Would you use VertiPrep for veneers? We do. We use for veneers, however, it's going to be slightly different because it is now a non-prep or prepless veneer. And those now all have margins which are supragingival. So yes, we do. It's a non-prep veneer, and we use that 0.1 of a millimeter margin, and very often we thin it down once it's been bonded in place. So yes, for veneers, but supragingival for veneers because I'm bonding. I don't want to be bonding subgingival if I can help it. Sarah, any tips how to manage bleeding? Yeah, one word, astringident. Okay, astringident is an astringent material. Okay, and we use astringident. I think that's marketed by Optident. Issue kit, which you go and buy. If you're going to go and buy it, make sure you buy the liquid, not the gel. And it's important that you don't dab it, you use an infusion tip. So it's a syringe with an infusion tip, and you squeeze this material and you burnish the soft tissue at the same time. The other thing you should be doing is making sure that you are aspirating a long way away from the margin that you're stopping the bleeding around. If you get too close with your aspirator, it means it dries out all the tissue. You get this horrible black coagulum there. So astringent is it tastes horrible. So you have to warn your patient, this is going to taste foul, but make sure your nurse aspirates a long way away. And by using astringent, you stop the bleeding instantaneously like that. Really excellent product. Revolutionize what I do. Sharon, what's my preferred method for cleaning, disinfecting your prep before bonding? Two things there. First of all, I've sealed it. So I will go back and re-etch it. If I'm cementing, I've sealed it. I'll go back with some chlorhexidine and a little bit of chlorhexidine scrub. You can either use chlorhexidine or there's some proprietary brands out there as well. Irina, fantastic revision. Thank you. Yemi, thank you very much. Brilliant presentation. Okay, guys, that's all the questions done and dusted. Thank you very much for listening. I hope that you've enjoyed it. I hope that you'll come to more of our webinars. Please visit the Tipton Training website, sign up for more webinars. We're here to teach, to pass on all of the information that we possibly can do. Have a look at all the courses we're doing. We'll be starting up the courses again shortly. And if you're interested in a PG certificate or diploma in restorative, aesthetic, operative dentistry, then please come and visit us. Alternatively, drop me a line, drpaultipton@gmail.com, and I'll answer you. Again, thanks very much indeed, and I look forward to speaking to you again soon.